Hello and welcome to this short video tutorial about ultrasound-guided peripheral IV cannulation. I'm Michael Trower, an A&E doctor from London with a special interest in point-of-care ultrasound, and I've been doing ultrasound-guided cannulation for about 6 years. So we'll go through a few slides to cover the basic technique, and then I'll talk you through a couple of live videos, and finally share a hot tip to ensure you never again suffer the humiliation of your cannula tissuing. If you're already reaching for the ultrasound machine, then presumably your patient has poor veins. But every patient will have something accessible. But the choice of vein can be as important as the actual insertion technique. So look for veins that are superficial, well, as superficial as possible, straight, so not branching off at funny angles, as large as possible, and preferably located away from arteries and with no nerves in your needle path. Also, they should be ergonomically convenient. So in uncooperative patients, for example, the basilic vein can be difficult to access, being so medial in the upper arm. So a cephalic vein may be a better choice. Also optimize your ergonomics in general, so adjust the height of your machine and also the bed to suit your height, whether you're standing, sitting or kneeling. So in terms of specific vein choice, I normally start in the forearm, try and avoid skin creases or joints because cannulas tend to tissue if sited in these locations. And then I move on to look generally for the brachial vein, which is just adjacent to the brachial artery. If you're going to cannulate this vein, just be careful you don't go through the median nerve to reach it, and try and access it just before it dives under the lip of the biceps muscle. Another option in the upper arm is the basilic vein, which is usually just a centimeter or two medial to the brachial. And the advantage here is there's no associated artery. But as I mentioned, sometimes you need to have an assistant hold the arm externally rotated to be able to access this vein. Other options are the cephalic vein, which is in a more convenient place in the upper arm on the lateral aspect. And if you're really struggling, the radial vein, which is just runs along the radial artery, or even the great saphenous vein in the leg. There are 3 different techniques, but I'd recommend technique number 1, which is where you continuously follow the tip of the cannula in transverse axis. Technique number 2 is where you place the vein in the middle of the screen, insert the cannula at the middle of the probe, then drop the probe and simply advance until you have flashback. This is easy to learn, but not reliable. Technique number 3 is cannulating in long axis. Some people seem to like this, but I find it's much more difficult than in transverse and doesn't really add anything. So you've selected your vein, cleaned the probe and the skin. Next, position the vein in the center of your screen. There are various functions that will show the middle of the screen if you find this helpful. For example, on my Sonosite export, you go through more controls and then center line. On other machines, sometimes the easiest way is just to press M mode. Then adjust your depth, remembering that the vein may dive deeper as you follow the tip of the cannula proximally. Once you've pierced the skin, only look at the screen. There's really no reason to look back at the cannula, other than perhaps to confirm flashback, but eventually you don't even need to do this, as you'll know when you're in the vein. Then follow the needle tip into the vein lumen, and then advance along the vein a little before finally retracting the needle and advancing the cannula as normal. So here we have a video of me cannulating the basilic vein. You can see the white dot of the needle tip coming down from the top of the screen, popping into the vein lumen, and then I actually advance along the vein a little before finally retracting the needle, just to make sure I'm well into the vein. Otherwise, occasionally if you retract too early, I find sometimes you can't advance. And here's an example of me cannulating a brachial vein. So you can see the artery just to the right, and again the needle tip is coming in from the top of the screen. we're slowly edging the needle along and following it with the probe. So as we advance the needle, we move the probe away from us. So we're only following the very tip of the needle, not the shaft. And again, once we're in, we keep going a little bit further, being careful not to go through the back of the vein. Tissuing. It's annoying. But luckily, thanks to Dr. Pandu Rangadu, we know it can be prevented. All you need to do is make sure 65% of the cannula is in the vein. So if your cannulae seem to be tissuing a lot, it could be because you're using short cannulae like 20 gauge pinks instead of 18 gauge greens. Now don't worry too much about this next slide. You don't have to do any SOHCAHTOA trigonometry calculations. The point is, greens are actually quite a lot longer than pinks. They're 45 compared to 33 millimeters. So particularly for deep veins, it's much more likely that a good proportion of the cannula will be in the vein. As a rule of thumb, if you're cannulating a deep vein, for example more than a centimeter deep, use at least a green and don't be too shallow, so go in at about 45 degrees. There's not much benefit in using a grey or an orange, as in a 16 or a 14 gauge, because these are only 5 millimeters longer than a green. But a pink is significantly shorter. So as a rule of thumb, use a green and don't go in too shallow. Practice. Practice on patients who don't even necessarily need ultrasound guidance, just to get the bimanual coordination. Whenever you're doing a resus shift and the ultrasound machine's right there, just take the opportunity to practice. It's quite a steep learning curve. I think once you've done about 10 or 20, it becomes fairly easy, and then once you've done 50 to 100, you could often get a cannula into just about anyone, even if they're agitated and it's a tiny, deep, spidery vein. You'll be surprised by what you can cannulate once you've done a large number of these. The same technique can be applied to other procedures. I quite often use ultrasound guidance now for ABGs. I find it's quicker and less painful for the patient, and also another advantage is there's no uncertainty regarding whether it's venous or a mixed sample, because you've actually seen the tip of the needle in the actual artery. Similarly, for arterial lines, you can use exactly the same technique as for peripheral cannulation of veins, and obviously for other procedures like central lines and nerve blocks, it's mandatory. So thanks for listening, and remember, there's no point in being an expert in ultrasound-guided peripheral cannulation if the planet is completely inhabitable due to climate change. So ask yourself, could I be more politically active? There are so many groups to get involved with at the moment, all the way from traditional groups such as Greenpeace and 38 Degrees, all the way to new exciting movements such as Extinction Rebellion and the Fridays for Future school strikes. If you're not convinced, listen to this amazing TED Talk from Greta Thunberg, the inspirational 16-year-old Swedish schoolgirl. Thanks for listening.